And it appears that we are live. Welcome, welcome. It is Thursday, July 1st. That means it's the 1st of July. So welcome to the 1st of the month. Welcome to July. It is 7:01 p.m. on the East Coast. This is OCD Town Hall on food-related issues. We have an excellent panel for you today and some really good talking points, things that I know I can relate to. So as always, we're going to give it a couple minutes and let people get in. So if you're here, let us know you're here by saying hello and where you're from. And I don't know. Hi, Loretta. And you're welcome. Let's see. You know what? Let's do it. Favorite food. So where you're from, favorite food. We'll start with that, and then we can talk about other stuff from there. So, but thank you for joining, Loretta. We appreciate you being here.
Chicken Parmesan, without a doubt.
Really?
Yeah.
Is it from a specific place, Kyle, or?
There's one specific restaurant in South Florida that I think has the best chicken parm in the country.
Have you eaten all the chicken parm in the country, or is that just a?
You know, I'm missing 3, so I shouldn't say that yet. There are 3 places in Montana I haven't been to.
All right.
Yeah, so I'll get to them.
Okay. Cool. Chocolate. What a great option. What a great choice, Loretta. If you're just joining us, welcome, 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 welcome. Please let us know you're here. Say hello, where you're from. And we're going with what your favorite food is because this is food-related issues. So we've got probably another 40 seconds to go. And then, hi, Ella from Kentucky. It's good to see you. And then we'll get rolling. So in the meantime, hi, Summer. My favorite food is Mediterranean. See, you can't beat hummus. Hummus is amazing. I love Mediterranean food too, Summer. And I have your email, and I will be responding to it. I was traveling all last week, so I'm catching back up. But thank you. Becky, chicken wing. See, I love chicken wings too. I think that's a great choice. Chicken gives me a lot of anxiety, though. In general, chicken gives me a lot of anxiety. But I do love chicken wings. We're going to jump into and get right straight to business. But in the meantime, please keep saying hello. Let us know where you're from and continue to feel free to list your favorite food. Also worth noting up at the top that we'll, of course, be doing a Q&A, getting to lots and lots of questions and thoughts. So, feel free to load them into the comment thread. We do go in order. Hey, Kristen. We do go in order. So I will back up to the top and go back through questions. And we'll get started about 45 after the hour. So with that, I love Mexican food too, Amanda. And yeah, New York pizza is delicious. Hey, Felice in Texas was just in Houston. It was ridiculously hot. Okay, now that I'm rambling, my name is Ethan Smith. I'm the national advocate for the International OCD Foundation, which simply means I have OCD and I won't stop talking about it, or in this case, talking at all. Tonight's town hall is on food-related issues. Before we get to our panelists, let's go over some quick housekeeping. So as usual, this town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. International OCD Foundation is not a crisis hotline. It should not be used if you are in distress or feel unsafe. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. Also, we always want to be respectful and kind of others and ourselves. We'd like to create as safe a space as possible. So it's always important to remember that although we talk about extremely open, vulnerable, and honest topics, this is still online, on the websites, on social media, and will live there. It is being recorded. So keep that in mind as you ask questions. But with that, there's no tolerance for hate or unkindness. And we'd like to create a safe space as possible as we support one another because we're all in this together. So with that, without further ado, let me get to our panelists and let me introduce. So first we have Dr. Shanda Curiel. Dr. Curiel is a licensed psychologist with a private practice in Kansas City, Missouri area, specializing in OCD, BFRBs, which is body-focused repetitive behaviors, tics, and anxiety disorders. She has been working with OCD in various levels of care since 2011. She also teaches graduate courses and frequently provides presentations to other professionals and the community. Thank you, Shanda, for being here.
Thank you for having me.
Next, we have Dr. Marla Daigler. That was terrible. Much harder last name. I apologize. Dr. Marla Daigler. Dr. Daigler is a licensed clinical psychologist and executive director of the Center for Emotional Health of Greater Philadelphia, multi-site outpatient service provider specializing in evidence-based treatment of anxiety disorders, OCD and related disorders, and neurodevelopmental disorders. Dr. Daigler serves on the scientific advisory board of the TLC Foundation for Body-Focused Repetitive Behaviors and on the faculty of TLC's Professional Training Institute. She serves as the board president of the board of directors of OCD New Jersey, the New Jersey affiliate of the IOCDF, consultant for the New Jersey Center for Tourette Syndrome and Associated Disorders, and visiting clinical supervisor at the Rutgers University Psychological Services Clinic. Dr. Daigler is also a parent of a child with OCD and comorbid avoidant restrictive food intake disorder. Thank you, Marla, for being here. Appreciate it.
My pleasure.
And I owe you $10 for your last name. Okay, and last but not least, we have Kyle King. Kyle is a rising sophomore at Yale University studying neuroscience and is a research assistant at Yale OCD Research Clinic. Since recovering from OCD in 8th grade, he's had a passion for advocacy and empowering others to fight their OCD, participating and helping organizing many IOCDF events. Aside from his work with the IOCDF, Kyle enjoys singing, playing guitar, and tutoring kids around New Haven, Connecticut. Thank you, Kyle, for being here.
My pleasure as well.
Awesome. So tonight's conversations is on food-related disorders. Let's start broad. So, Dr. Daigler, quickly just go into what all can food-related disorders encompass in terms of OCD and food?
Well, food-related issues really are very pervasive throughout OCD. So we see it manifest in avoidance of a lot of different kinds of foods for a variety of different reasons. We see ritualization around food preparation, around the eating of food, and we see overlap with comorbid disorders like ARFID, as you mentioned, but also eating disorders and specific phobias like emetophobia. So really the fear of or distress surrounding and disgust surrounding, not just anxiety, but disgust also surrounding food is really very prevalent within OCD.
And for those of you that have questions, emetophobia is specifically the fear of vomiting or throwing up. Shanda, do you see anything in your practice that seems to be more occurring than others in terms of some of these examples that Dr. Daigler gave us?
Mm-hmm. Well, I would say in my practice, the more common food concerns are either with just right feeling, things having to be just right, and when you consume food, how rules that you might follow, things so it feels just right, like repetitive sips or bites, things like that. But also emetophobia is definitely one. That's usually one that we find after a good assessment and functional analysis. Then we realize that that is a part of the OCD, which is the fear of vomiting. And I would say I'm seeing more and more of the fear of emitting an odor when someone doesn't actually emit an odor, and so there's some fears around especially stronger seasonings, but could be anything from garlic to coffee, onions, anything like that. And definitely health and contamination can play in with food as well.
Excellent, thank you. And Kyle, I know that you'll be sharing your lived experience in a minute, but you're also you've also done a lot of advocacy as well as you're a bright guy. So no, you're not. What have you seen from your opinion as either with yourself or talking with others in terms of food related issues around OCD? What have you found to be prevalent with individuals that you've worked with or talked to?
I think most commonly I see contamination concerns regarding food. And that can be as kind of a direct association as undercooked chicken, like getting scared that you might get salmonella from your food, or maybe that there might be mold on your food, which could hurt you if you take it in. I know personally, my biggest problem with food was I had magical contamination fears surrounding my food. So if I was contaminated one day and I ate chicken parm, then the next day I wouldn't be able to eat chicken parm, or else it would give me back that contamination. So I think, and we kind of talked about this a little before, behind the scenes, like no matter what your OCD is, food's gonna somehow get caught up in the web of your OCD. And when I talk to pretty much anyone, food gets in somehow. There's some ritual about food.
Thank you, Kyle. Dr. Daigler, you're nodding your head. What are your thoughts?
Yeah, I mean, I think Kyle makes a really good point in that OCD really likes to grab onto the things that are most important to us, and we need to eat. We need to eat every day. It's not something that we can cut out of our lives. So OCD often gets wrapped up in food-related concerns.
There are some great topics to touch on, and I also am already seeing some great questions. So typically we get way behind on questions, but I think the questions are going to lead us to the topics that we want to talk about, and if not, we'll address them anyway. So I'm going to take a little bit of a turn here and start answering some questions initially, then we'll jump back, sort of back and forth. And so if you're joining us or you just joined us, please feel free to load your questions into the comment thread. We will get to them in order. But with that being said, Amanda at 703 had a question. Best ways to get someone to help you when you're having issues with food because of your OCD. I'm finding a lot of opposition in helping me because I don't have, quote unquote, an eating disorder diagnosis that I fit under. Dr. Curiel, what do you think?
Well, my first thought is, of course, to try and seek out an OCD specialist. They will help you, kind of untangle which kind of category it fits in, which then informs what kind of treatment you need. But it sounds like you have, you suspect that it's not a traditional eating disorder and that it's OCD with food-related issue. And I mean, my go-to for referring individuals is IOCDF. So kind of starting with that directory and maybe speaking more to your symptoms when you're inquiring with a therapist versus labeling it as a condition, because they might be more likely to say, oh, that's, not my area of specialty, or kind of make a prejudgment about it. And so that way you have the opportunity to actually get your foot in the door and have an intake and be able to do a really good assessment.
Great advice. Dr. Daigler, do you have anything to add?
Yeah, I would add also that really there are many more resources than there had been prior to the pandemic, because the interjurisdictional practice regulations have been growing in leaps and bounds. So just because you think that perhaps there are no therapists in your area doesn't mean that you can't access care. You might be able to access a very good therapist who specializes in OCD through telehealth.
Absolutely. And you can, access pretty much anyone in your state, and also multiple therapists have multiple licenses in multiple states. And so it's definitely more available than it's ever been. I guess one of the false silver linings of COVID. So thank you, Dr. Daigler. Please keep the questions coming in. And as we go, Kyle, I'd like to hear a little bit about your personal story around food, OCD, and how it all relates to you.
Yeah. So I like eating, but who doesn't? And when I was in 8th grade, my OCD got particularly severe. And the primary fear that I had was contamination. I was scared of getting contaminated by autism. Like I could contract autism via touch or touching a surface that an autistic person had touched. But because I went untreated for a while, my OCD kind of ballooned into every single sphere of my life. And as I touched on a little bit, it ended up affecting food. And I had good foods and I had bad foods. And by good and bad, there were contaminated foods and not contaminated foods. And if I was contaminated one day, then I could only stick to the not contaminated foods. And if I was like clean, then I could only eat things that I had already eaten when I was clean. And it just became a process where like I would have to tell my dad what to cook for dinner, because if he cooked a contaminated food, then I would get upset and then I couldn't eat that night and then I'd go to bed hungry. And eventually with the proper treatment, I was able to work through those food-related concerns that stem directly from my OCD. And then a little bit later in my life in high school, I started to get caught up in like what is a good food and bad food in terms of health and calories. And I started to categorize like fruits and veggies as good, and then like chicken with cheese on it, which was unfortunate for me, as bad. And then slowly that ballooned up into anorexia, which kind of presented itself in my head as very similar to OCD, because my parents thought it was just another manifestation of my OCD because I kept just obsessing about whether or not something was a good food to eat or a bad food to eat. And through what essentially felt like ERP, which is just kind of building a hierarchy and attacking the foods that I thought were bad over and over and over again, I was able to find my way out of that. And that's a long-winded way to say that my journey with mental disorders has been very wrapped up with food-related issues for the entirety of my life. And they're a particularly frustrating symptom to have because, as Marla said earlier, you can't get around eating. And it's really difficult, especially I remember in high school or in middle school, my friends would want to go out to eat at like a taco place. And if that was a bad food, then I couldn't go out with my friends. And it would just make me really sad when I was little.
Thank you, Kyle, for sharing. I'm wondering, and I'll throw this out to Dr. Daigler or Curiel, where is that crossover from food-related OCD and eating disorder? How can it start as a food-related, an OCD subtype or symptom, and move into an eating disorder? Are they usually how frequent is the comorbidity of those two disorders? Just maybe tease apart some of this for us. Go ahead,
so there is a comorbidity between eating disorders and OCD, and certainly I think Kyle gives a really great example of how OCD can lead to eating disordered behavior. The main difference that we really keep in mind is the concerns that people have. So the concerns being contamination related and the avoidance behaviors and the ritualization around food and food preparation related to OCD because of various fears of getting sick or of harm or some OCD related obsession is certainly within the OCD category, even though it eats into food related problems. Whereas eating disorders, traditional eating disorders like anorexia or bulimia, really involve a distorted perception of one's body. So it's a concern for gaining weight, a concern for one's body shape, and the restrictions and the ritualizations around food come because of the anxiety associated with those concerns.
Dr. Curiel?
Yeah, I mean, the way that I sort of explain it with my patients beyond kind of the core fear of the intrusive thoughts or of the surface fears, aside from that, might be that with OCD, usually there's going to be like some kind of, there's a broader range of consequences that you might have usually, that someone is either catastrophizing or maybe, I guess it could maybe include some just I'm going to be uncomfortable kinds of things. So sort of the wide range of fears of what could happen if you didn't engage, in that behavior. And also in my own practice, I do consider some of the compulsions as disordered eating when it gets to that level. But not necessarily in the traditional category of eating disorders, which is what we think of with anorexia, bulimia, binge eating, and that kind of thing.
You just answered my question, and apparently I answered Summer's question without even knowing she asked it, which was, what is the difference? So thank you, Summer. Let's jump to, there's a bunch of comments on ARFID, which we also avoidance restrictive food intake disorder. I have a personal experience with this that I learned about a year ago during a town hall and was like, oh my gosh. But before we dive into to me, Dr. Curiel, can you quickly sort of go over what that is and how it impacts individuals with OCD?
Well, what I have noticed more often is sort of a rigidity and around what someone is either liking or willing to eat. That definitely impacts the repertoire or the variety of foods that they're willing to eat. So lots of restriction and rigidity, and sometimes it can be kind of along the lines of, okay, I'm excessively picky, but I think also it can lead to much larger consequences if someone is too restrictive that could lead to health concerns and that kind of thing.
Dr. Daigler, additional thoughts?
Yeah, so ARFID is a really interesting problem, and unlike OCD, it manifests in very young children. We even see it starting in infancy, oftentimes, where when solid foods are introduced, children don't accept that and they reject it. And ARFID really can fall into three basic subtypes. There's a picky eating kind of subtype where they have particular preferences for or rejection of a particular sensation when eating, so like a texture, for example, or a color. Then there's also those who have a reduced interest in food altogether or poor appetite. And then there are those who fear the consequences of eating, like fear of choking, fear of vomiting, and that leads to restriction. And the thing about ARFID is that it leads to the failure to make or maintain nutritional gains. And so these are kids who don't meet the growth curve that they're expected to make. And they also suffer from psychosocial impairment as well because they're so restricted in the food they take in. So it's a really challenging problem. But unlike the other eating disorders, unlike anorexia or bulimia, there's no concern for one's weight or weight gain or body shape. There's an absence of that. It really is just associated with anxiety, disgust, it not seeming right or edible, or they fear the consequence of eating.
So my personal experience with ARFID, and again, I made the connection during a town hall last year, was that when I was 6 years old, I was at a baseball game and I sneezed and phlegm got stuck in my throat and I choked. And then the whole time that day, it felt like something was still stuck in my throat and I couldn't get rid of that feeling. Well, then as I started to eat things, I was afraid, what if this gets stuck in my throat and I choke? And very, very quickly, my diet, which was clearly not a problem now, and wasn't a problem then, shrunk. And it sort of, I had one of two food options. I was only eating chicken broth or frozen mashed potatoes. And that was the case for months and months and months. I lost a ton of weight. I was a really skinny kid at that age. Actually, it was addressed through, it was the mid 80s, dating myself. So it wasn't addressed through psychological measures. It was addressed through, his tonsils are big, we're going to take his tonsils out. And then I went on to sort of the next OCD fear. But would you consider that to be sort of ARFID?
Yeah, it certainly sounds like it could have been. Yeah, and it sounds like you were quite restricted and it really impacted your functioning and your ability to eat.
Yeah, so that was my experience. And I've also obviously talked with a number of kids. Is there a reason why it's generally a pediatric condition? Can ARFID develop in adults? What is sort of the research behind that?
So there's actually very little research on ARFID. In fact, ARFID is a new diagnosis in the DSM-5. And so the research that we have is really very new. Previously, it was considered selective eating or oftentimes diagnosed as eating disorder not otherwise specified. In other words, it just didn't fit into the eating disorders categories that were existing prior to DSM-5, but it was clearly disordered eating that were impairing people's functioning. So we really know very little, but what we do know is that it typically manifests in kids, and then typically over time, people broaden their repertoire a bit and they learn to get along. You know, these are not kids who are in college are going to go out with their friends for Indian food. They're probably going to go to the dining hall and have pasta with butter, but they figure out, how to get by. They don't become adventuresome eaters, but they learn how to kind of get along. So by the time they're adults, we probably all know people who were like this as kids. They just tend to be people who stick to some very basic food groups.
That makes a lot of sense. Kyle, was anything in your life as a young kid sort of encompass food for you?
I don't think in kind of a sense that would be qualified as ARFID. No, food related issues really came up for me when my OCD started.
How did you feel when you? Whatever. Don't laugh at me. No, but how did you feel in all seriousness? Like, I know when I got a second diagnosis for bipolar, which I rarely talk about, but that was a good time to mention it. I felt very stigmatized. I was stigmatizing myself because I already had this one thing and now I've got to add something to it. How did it feel for you to sort of like feel like you got through, this really intense OCD journey, and I met you during that journey. And I remember, you being afraid to touch and go near individuals with various exceptionalities because of them transferring it to you. How did it feel to sort of have to tackle now, an eating disorder? And honestly, I know you, so how did you come out stronger because of it?
Well, I mean, it wasn't fun. But I will say that they did feel very similar in the speed at which they kind of took my life off track, and the therapy felt very similar, at least the way that I did it. So I was treated at the same clinic for my OCD and for anorexia. And really it was again, like a stepwise exposure process that took me from the easy stuff to the hard stuff. And as I worked my way up to the hard stuff, it got easier and easier and easier until I felt like I could move around the world again. But I feel like it makes sense that like I had both. Like they, in terms of how they progressed in my head, like it happened exactly the same way. Like it started on one day with one event. I think the first thing I remember with the OCD was I touched a library book and I had the thought of maybe an autistic person had touched it. And then with anorexia, I decided one day, just randomly for no real reason that I could comprehend at that time, like I'm just going to have grilled chicken today instead of breaded chicken. And both times, despite the fact that I was in relapse prevention mode from my OCD, like I already had been through ERP, I already knew the protocol, I gave into that thought. And then that whole kind of part of my life with anorexia ensued. So I think the way that it made me stronger was that bout with anorexia got me on my relapse prevention game now, because it reminded me kind of how insidious OCD is once it's in your brain and how quickly it can take your life over again if you give it a little bit of space.
Thank you, Kyle. I appreciate you sharing. I'm gonna go back up to questions. So if it looks like I skipped your question, don't worry, I'll go back up. But I'm gonna ask Erica's question at 7:14 p.m. as it pertains to exactly what we're talking about. She wrote, "I have both a diagnosed eating disorder and OCD. I feel like whenever I try to address one disorder, the other gets worse. How do you suggest balancing treatment with both?" Dr. Curiel?
Well, that's really insightful, Erica, because that is often what happens. As one waxes, the other will wane, and even we see that even when you are in treatment, and we see that as depending upon if you're just working on one condition, we'll see the same thing happen as you get one better. Kind of, the other one comes to the forefront. And I would say this: if there are particular skills that you can apply to both conditions to kind of temper maybe the one that isn't quite the focus, if there are any skills that you can apply to that one as well as you go along, that might help keep it in check a little bit. Because I think that's the thing, is anytime you're not sort of living the exposure lifestyle, I guess, if you will, OCD or an eating disorder can kind of creep back up and get bigger and bigger. And there is some overlap in some of the skills that I think, could be helpful. And, some simple things to think about, but not necessarily implement would, be like keeping in mind radical acceptance and getting out of your comfort zone and challenging yourself. That's where the growth happens. And sometimes, you have to just ride the wave out if other like skills aren't really working. But if you do have a therapist that could help you with both, it's a good idea to check in if another condition is kind of getting a little out of hand too.
Thank you, Shanda. Dr. Daigler?
Yeah, I mean, in general, right, you're approaching both of these problems with exposure and response prevention, right? So the better you get at noticing your internal discomfort, whether it's anxiety or whether it's another kind of distress like disgust, or whether it's an uncomfortable thought or an image or a sensation, a memory, any kind of internal discomfort, have that be a red flag for you. Here's something that's telling you, I need to avoid this, or I need to do something to make this feel better. And that should be an indication to you that you need to make room for it and push past it, regardless of whether it's specific to OCD or specific to food restriction.
Kyle, when you had your onset of eating anorexia, was there an uptick in your OCD as well?
Yeah, there was. I got more contamination, kind of scared of contamination, just like I was in 7th grade, but then my anorexia kind of just took over my life very quickly. To address that question, though, one thing that I like to do, and this is
that's what I was going to ask you next. Go ahead.
I have the mind of a child, so this is how I conceive of things, but I think it's helpful when fighting OCD and anorexia. I like to think of them as like like separate little monsters. And because I had OCD first, or I was diagnosed with it first, I picture my anorexia as a monster, like as an OCD monster with like a ghost, like a sheet over it. So it's like pretending to be like anorexia. And every time I like thought about an exposure that I did when I was little and like to beat my OCD up, I would like then think about my anorexia monster and be like, come on, man, like really, like you're just gonna don a new gown and then try to trick me. And thinking about it like that, like it made me more courageous and made me more willing to fight. So maybe thinking about, maybe your ERP is helping your OCD at the moment, but not your anorexia. I like to think of them as just two sides of the same coin and say like, okay, I can take one, like what? I can take two. It doesn't really matter.
I love that, Kyle. Thank you. Before we get on to more questions, because we're sort of building up, so I think we'll dive into that. I know, Dr. Curiel, you wanted to talk a bit more about olfactory reference syndrome, which I had not heard of until we came here. So if you wouldn't mind, again, sort of defining what that is and maybe talking a little bit about it as well.
Sure. I mean, just some background. It used to be thought of or conceptualized as more of a psychotic type condition. It's not even necessarily formally recognized as a condition in the DSM-5 right now. However, we do understand now and conceptualize it usually as kind of rearing its head within OCD or within BDD. And what that means is usually when I do an assessment and I'm asking about those kinds of questions, it's just one of other symptoms I'm going to see. It's just one set of symptoms within, other themes or fears with OCD or maybe BDD concerns. And so basically it's just a belief that you're emitting an odor that you actually are not. And that belief is sort of reinforced by interpretations of other people's reactions and actions and interpreting their facial expressions. Did they move away from me because they think I'm emitting an odor? It can be very loosely related as well. Did they open the blinds because they thought that then they're going to go open the window and that's going to let some of the odor out? Are they not wanting to sit next to me? Things like that. So there's a lot of compulsions that go into this, such as trying to camouflage with scents. So perfumes or candles, soaps, deodorant, all of those kinds of things, excessive use of them, excessive products. But it can also be wearing certain clothes that they think will hide any odor that might be emitting. Avoidance is huge, just like with all other anxiety disorders. Avoidance is a big part of it. And so that might be avoiding activities that cause one to perspire, or where you'll be up close with someone else in close proximity. And so the one caveat I will say is that with ORS, so there isn't actually a fear, but there is a portion of individuals who, after maybe they've had this condition for so long, usually people will report that they don't smell an odor themselves, but there is a portion later on that might get to the point where they believe they smell the odor themselves, which could be any kind of foul smell. And the one caveat I will say, though, is that I feel like the level of insight is less, and sort of if we're looking at the level of belief, it is approaching closer to more of a delusional, rigid type belief. It's stubborn with treatment, but progress can be made. So.
And just to clarify, so does the belief is that these potential smells, the root cause is a food or an ingested related ingredient?
It can be anything. It could be things that are organic, not necessarily from food. Anything from, a bodily scent to caused by something put on the skin or ingested. Just food becomes a big part of it because people attribute that to causing odors. So.
Okay. Dr. Daigler, do you have anything to add?
Yeah, I thought that was really nicely summarized. We definitely see some food avoidance as well. Foods that have strong odors like garlic or curries have certainly seen people avoid dairy products or beans, different kinds of legumes, because they fear that they'll become flatulent because of it, and then people won't want to be around them and they'll be embarrassed and ashamed.
With that, I know we have a lot more topics to go over, but questions are piling up and they're really great questions. And I think a lot of people are being brave and vulnerable. And so I think we'll touch on a lot of these now. So, Fran, no need to post this because it's sort of divided into 3 different comments. I'll ask it slowly. But Christine at 7:05 p.m. asked, what would the difference in treatment ERP be around avoidant eating when the underlying fear is the feeling of disgust rather than the fear of illness? Are there ERP suggestions for addressing the fear of the feeling of disgust? I usually go with who's nodding their head harder. Dr. Daigler, that's you. Who do I end?
So, I mean, we're going to approach it in the same way. We want to do exposure and response prevention. The main difference really is that disgust doesn't habituate. People don't get used to the feeling of disgust as quickly as they do anxiety. So, ideally, we want people to habituate, right? We want the anxiety to come down. Although, some people don't habituate as well. And we try to emphasize the importance of learning to tolerate distress around these things and to decrease all of the avoidance behaviors so that people can live full lives. And so really with the feeling of disgust, it's really the same kind of goal, the idea of being able to tolerate a feeling of disgust, that something doesn't need to be avoided or cut out or ritualized around because they're trying to avoid the feeling of disgust or make it better in some way. So really, it's just a lot more exposure that's necessary as opposed to what we typically do with anxiety.
Thank you, Dr. Daigler. At 7 to 9 p.m., Taya writes, how would you treat very severe symptom of religious OCD when the patient is not eating nor drinking for weeks and is now getting malnutrition through a hose in a hospital? At the moment that kind of feeding works as an accommodation to the symptom, how would you start ERP in this kind of situation? This is a very complex question, but Dr. Curiel, feel free to start.
Mm-hmm. Well, in that particular scenario, I'm probably, especially being an outpatient, traditional private practice outpatient, I'm probably not going to be involved until they're medically cleared and ready to transition from a medical setting. And who knows if there'll be sort of a medical clearance and then a residential psych treatment episode that would need to occur first. I imagine there would be. And so, I mean, I would, at that point, as long as they were stable, I would approach it in a similar fashion of exposure like I would with other patients. But I would definitely, in that kind of scenario, want to involve other people. So that might be, their physician, if they're seeing a dietitian by chance, whoever their religious leader is, if I could have them be involved as well. Oftentimes that can help with not being so overly strict and rigid and even misinterpreting some of the teachings. So I would definitely complex issue, more complex treatment approach, I think.
Yeah, for sure. Go ahead, Dr. Daigler.
Yeah, I would just add that, in addition to wanting them to be medically stable before we would do anything from an outpatient perspective or to really engage in ERP, really fundamentally the first thing of importance when someone is being supplementally fed is that we really want to get their weight up. before we do anything else. We want to make sure that they're not lacking in nutrition, because they're not going to be as responsive to treatment, actually. It's just not going to be able to be as effective. So not only do we want them to be stable, but we want to make sure that first things first, we need to get their weight up so that they're not starving. When the body is starving, it tends to want to stay stuck in food restriction. So regardless of whether it's OCD or a traditional eating disorder, or whether it's ARFID, we really first want to make sure that they are not starving, because their bodies won't, it won't respond to treatment in the same way.
Kyle, I saw you nod. You probably just agreed, but in case you had an interesting thought. You're on mute. Not so bright, are you?
Well, I mean, in the vein of not being too bright, I don't have too interesting of a thought. I just, like, there were times when I wouldn't eat for whole days, which is obviously nowhere near this kind of level. But for me, it always came back down to, like, well, like, what can you do? And, like, if your weight's stable, like, what's the littlest thing you're willing to do? If it's just have a bite of, let's see, what did I start with? Grilled chicken. If you just have a bite of grilled chicken, if that's all you can do, and that's going to provoke enough anxiety to, like, get you up a little hill, and an anxiety hill that you can come down from, well, then let's go do it, and then let's work up from there.
So I'm going to weigh in, because I played a doctor on TV in 2003. True story. And the reality of it is, Taya, is I think that, at the end of the day, everybody's saying there's a holistic approach. And that's really probably the best way to go about it, in my opinion, which clearly is the most important here. I'm in a really sarcastic mood. I apologize to pretty much everyone on here. But the reality of it is that there's a lot of different modalities of treatment, and we have to think of this as like a baby step systematic approach to how to get your loved one better. So the idea is that maybe while they're being medically stabilized, maybe while they're increasing their weight, what can we teach them about OCD? What can we teach them about OCD education? How OCD and the thinking around OCD affects the eating? Maybe there's all kinds of willingness to change protocols, right? Where we can sort of change their thinking around and reframe, and to really just prepare the individual to want to engage in ERP or OCD treatment or therapy, even talk to a therapist. And to Shanda's point, can we integrate a religious leader in there that is hopefully pro mental health, because mental health and faith are not mutually exclusive. And we can get in there and start to cognitively dissect all of this and tweeze it out as we're stabilizing. I personally don't think it has to be one or the other. And then once they're medically stabilized and their weight is in a good place, hopefully we use that opportunity to then take whatever those next steps are. I think you're also at an advantage, because if they are in fact in a hospital, because therapy is so virtualized right now, therapists can meet them where they are. And so where it might have been harder to bring a therapist into a hospital setting before, you could do any type of therapy session virtually over computer or cell phone, whatever. So I think those are just options to think about, and really think of like a holistic, systematic approach, and understand that it's baby steps. I know the desire is, oh my gosh, my loved one is suffering, I want to fix it all now. And that's just not realistic, but we can take small steps to get them where they need to be. So hopefully that was insightful. Elizabeth at 7:15 p.m. asked, can stress-related symptoms be a driver for ARFID? Go ahead, Dr. Daigler. I'm telling you that nodding is key.
I got to start doing that instead. Yeah, absolutely. When kids are, teens are particularly stressed, they're more likely to be symptomatic for anything, for OCD, for ARFID. Absolutely. That certainly can be. Quick story, and if you, a teaser, if you go to the virtual conference in the fall, we're going to be giving a presentation on ARFID, and my son, who has ARFID, is going to be taking questions. So he'll be able to answer some questions from you as well. But we had a trip where we went to Europe a couple of years ago, and we thought that he was eating enough to be able to eat something anywhere we went. But unfortunately, he got a little stomach bug, and by the time we arrived, he got into his head that he thought that drinking water was actually what was causing him to throw up. And then he refused to drink in addition to refuse to eat. And I can tell you all about hospitals in Italy, if anybody needs to know, privatized and public. Just the distress of being away from home, the distress related to being sick, not feeling well, having a stomach ache, really got him very stuck and landed him inpatient for a few days. So I think it's a really good example of how any kind of stressor in your life, whether positive or negative, can absolutely increase the ARFID rituals and the avoidance behaviors.
Yeah, it's funny that you said that. I just got a memory that I hadn't had in a while, because I'm thinking about all my specific food-related symptomatology with OCD, and I completely forgot. I went on 2 trips to Disney where I was scared to eat because I was afraid I would have to go to bathroom in line because the lines are so long, and I was so scared that I wouldn't be able to, that I wouldn't have a bathroom to go to. Conversely, though, I was also afraid that I wouldn't be able to go to the bathroom, physically wouldn't be able to go to the bathroom. So I remember standing in line, trying to go to the bathroom to see if I had to go to the bathroom and then go to the bathroom. So yay, OCD is super fun and likes to attack from all sides. And now you know that was probably way too much information. It should have come with a trigger warning, but it's okay. We'll move on. Dr. Curiel, did you have anything to add to that? Or Kyle?
Oh, I was just going to say that, you know, in agreement with that. So definitely spikes in stress are going to spike really any condition, but especially the ones we're talking about. But I also see spikes around the times of big changes. Big life changes. If there's something that is sort of consistent in your life that you're unhappy about, that isn't really, you can't really change it right away, and it's causing extra strain and stress. Increases in responsibility. So oftentimes that shift from adolescence into adulthood, or maybe having a child, those kinds of things. So, and of course, not getting good sleep. It's harder to fight these conditions as well. So
That's such a great point too. It's always important to remember that stress, good or bad, increases OCD symptomatology, and ARFID is a part of that. So that makes total sense. Felice at 7:18 p.m. It's bad when you can only eat certain things on certain days from certain places. How would you tackle this if ERP is not working? It's not all tied to contamination. And that's it. Yeah, thank you, Fran. Go ahead, Dr. Daigler.
So I like to use ACT-informed ERP. So I would probably start off with really talking about what's important to you here. What are your values in terms of how you'd like to live your life? It sounds like you're feeling like this is difficult and it's a drag on the way you want to function. So I'd probably start off with exploring your values a little bit, and then talking about what gets in the way of you living those values. So what is getting in the way? And I know that, you know, these specific rituals are getting in the way, but more specifically in terms of, you know, what's showing up on the inside that's uncomfortable, that you're having difficulty sitting with and pushing past, so that we can figure out not just exposures, but ways to make room for that discomfort so that you can ride it out a little bit more easily before pushing forward with your willingness to engage in exposures. And it might be that, you know, there are lots of reasons why exposures haven't been effective. It could be that, you know, perhaps the exposures were not the right exposures for your particular symptoms. It could be that you were not in the right place to be able to engage in that kind of treatment at the time. It might be that, you know, you did it white knuckling it, that your willingness really wasn't there, that you were, you know, or that you were engaging perhaps in rituals while you were doing it. Lots of people engage in mental rituals, for example, and then while they're doing that, and perhaps their therapist doesn't even realize they're not making the kinds of gains that they would expect to see. So, you know, to be able to put together a plan by really kind of figuring that out, doing a really good functional analysis and making sure we understand how you can be fully accepting of your internal experience as well as your external experience, so that you can kind of live the life that you want and not be restricted by the obsessions and the compulsions.
I'm a huge ACT fan. I thought that was an awesome answer. For me, in my own journey, non-food related, I always felt, and I even talked about it in my keynote, I think in 2014, ERP didn't work for me. ACT is what changed my life. But really what I discovered later on in self-reflection is that ACT really put me in a place where then I could dive into ERP and really embrace it and accept it. It just changed my relationship with my thoughts. To that point, Kyle, when you were really struggling, what were some things that helped you sort of embrace those really intense fears and the things that really scared you? What allowed you to get really scared? Did you start thinking about your values, what you might lose if you didn't do it?
Yeah, it's pretty much precisely that. I was 13 at the time. I was a middle schooler. I wanted to be hanging out with my friends and, just be doing what a normal middle schooler would be doing at that time. And I looked at my life and I thought about the fact that I couldn't eat with them when they went out, and that I couldn't hold my phone, and I couldn't go to school and live the life that I wanted to be living. And that made me really upset, and that made me really mad. And I didn't think ERP worked for me either for the first 5 months, because I was doing what Dr. Daigler said. I was white knuckling it, and I was doing the exposure because I knew that my parents wanted me to be doing the exposure. And then in my head, I would be undoing it, and I would go home and I would wash my hands, and I would sit in my room for 2 days until I was completely decontaminated. And then I would go and do another exposure and do the same thing. And I was like, why am I getting worse? So the real reason that I started to kick into high gear and was able to tolerate that anxiety was because I eventually looked around at my life and said, like, this isn't the life I want to be living. And I thought about my values, and I thought about the life that I wanted to have, and I wanted to have friends, and I wanted to hang out with them, and I wanted to eat whatever food I wanted whenever I wanted. And then I was able to get a little bit anxious to have that life.
And Kyle, I'm going to stick with you. And again, I'm jumping questions, but I will definitely back up. At 7:46 p.m., Fran Grace asked, my question is for Kyle. Question is, how did you go about starting to really want a recovery from an eating disorder for yourself? Do you have any advice for someone in eating disorder recovery who's riding the line of being fully committed to recovery and at the same time still near that I could relapse if I don't change now? I know you addressed pieces of that in your answer, but could you elaborate?
Yeah. The first thing and the most important thing is to be stabilized with weight. I dropped to 117. I was 6'1" at the time, and I weighed 117 pounds, which that was at my lowest weight, which is skinny. And when I was that skinny, I couldn't think straight. And I had a nutritionist that kind of just kept pounding me food, and whether I liked it or not, I gained weight. And when I started to gain weight, then I could think a little bit better, and I had a little bit of a freer head, and I could start really engaging with the therapy. I think a lot of the reason that I started to change, or I began engaging with therapy with my eating disorder, was I just looked around at my life and said, this isn't the life I want to be living. I think values work is probably the most important work you can do if you're struggling to start engaging with a therapy. Because I know, like, I get it. It feels damn near impossible when you're starting to start engaging with it. And it's a lot easier to give into your OCD than to fight it. At least it feels that way. But you never end up in a better place. And it always gets harder, and it gets harder every time that you give in. So why not just start now?
That's awesome, Kyle. And Kyle's story is really inspirational, and thank you for that. And I want to add to that, as I see some comments, but I'm not going to say who, is that, children, adult, wherever you are, this stuff works. This treatment works. I always talk about it in my own recovery. I was 31 before I found effective treatment for OCD, exposure response prevention, acceptance commitment therapy. Before that, I had been to a zillion therapists, all doing psychodynamic talk therapy for literally 17 years. I was in a really bad place, in a dark place. I always feel like if I get better, you can get too. And yeah, maybe it is easier in kids because their brains are still forming and it's malleable. Sometimes it's not, but the reality is, 5 months in Kyle's case, 5 years in other people's, 30 years in other people's, your destiny is in your hands. And that's the reality. Is all we can focus on is our focus and behavior moving forward. We can't go back. So, now's the time, right? Now's the time to really take the bull by the horns and run with it. The other thing I will add to it and to what Kyle said, and also Dr. Daigler, and I know Dr. Kirill agrees, is when I made identifying my values very, very specific, that's when I started to get better. And what I mean by that is I took a close look at what I was losing by choosing OCD. And I did, because for so much of the time when I was in treatment, I would keep hearing, you're not fighting your OCD. And I really didn't know what that meant. I don't know what not fighting my OCD means at that time. It just was too nebulous and ambiguous for me. But I could wrap my head around, if I choose OCD, that I'm choosing not to meet the love of my life, go on vacation, get a part in a movie when I was acting at the time. I mean, and I would get it real specific, like whatever that day was and my goals for that day. And when you start, when you start gaining insight and objectivity, you start seeing that fork in the road where you can either take the path of OCD or take the path of your values. And they're mutually exclusive. You can't do both. You have to choose one or the other. So for me, recognizing that I'm not choosing OCD, I'm choosing to not do what I love to do or what I'm dying to do or what I dream of doing. And when I started framing it like that, that's when it really started to have an impact on me, because the idea of me choosing no to the things that I loved really bothered me. And so for me, that was really effective.
I'd just like to add one thing really quick.
Please.
Just kind of going back to, I guess, the last two questions. When it comes to the ERP, I think one thing to keep in mind as well is one of the questions was, what if it's, this food on this day at this place, and it's, kind of a sequence of rules that are all together. One thing I might do if it feels overwhelming is, I'm always looking for willingness, but I might break that down into parts. So maybe knocking all of those rules out would, be really high in your hierarchy and feels like too much. So we might break it down into pieces and just change, one part of it, work at one part of it, and then build our way up to the rest. Like, it doesn't have to be a sprint. It should be, in most instances, people want to work gradually. It doesn't have to be, but people want to work gradually. And so it's more of a marathon, and it doesn't have to be everything all at once.
Thank you, Dr. Curio. Yep. Systematic baby steps. And the desire is to climb Mount Everest today. It's like the instant gratification in all of us. Like, we have to do it today. We have to do it now. I want to get, and I always use the analogy is that, as much as I want to go to the gym tonight and look like Mark Wahlberg when I leave, it's not going to happen because I don't go to the gym. But regardless, it's not going to happen. So it's it's the same thing. I love the exercise analogy, because you can't reach whatever your goal is, your fitness or weight loss goal, overnight. And it's the same thing with OCD and treatment. It's not going to happen overnight. It's consistency, it's persistency, it's all of those things. Is persistency even a word? Anyway, Kyle's doubting me, which means no, it's not. 7:19 p.m. Carrie asked, I recently lost over 50 pounds from OCD-related food avoidance. I've finally been able to stabilize my weight over the past 6 months, but I get a lot of comments from people complimenting me for my weight loss and asking how I did it. My weight loss came from a very scary and uncomfortable place, so how can I handle these questions? That's a great question. Dr. Daigler?
That's a great question. Yeah, I think it depends on your level of comfort in disclosure. You can say, I haven't been feeling really well, or you can, use it as an opportunity to teach somebody about OCD and say, actually I have OCD, and OCD has led, unfortunately, to weight loss. It wasn't desirable, but I'm working on it now, and I'm starting to feel stronger and better. So I think it depends on, whether you want to share that with that person or whether you decide that this is not someone that you are comfortable disclosing it to.
Yeah. Dr. Curio?
I think that was a perfect way of saying it. I feel like everyone has to decide what their level of disclosure that they're comfortable with. And I always tell my patients, start small, unless you're the type that's like an open book and you feel comfortable. If you're not feeling comfortable, start small. And if you want to add additional information, you can. But there are ways of answering questions where you don't have to give maybe all of the details, or, don't feel like you are required to engage in that conversation like you owe anyone an explanation for your weight loss either.
I think that's a huge point, Dr. Curio, and it was one that I was about to make, which is you don't owe an explanation. And with OCD so much, we feel like I have to tell them. I have to tell them what happened, what I went through. Here's the whole story. The reality is it's your story. It's your personal life. And, and you also have to recognize is they don't know. They don't know what you went through. And that's okay that they don't know. And they're not asking you about your weight loss out of malice, but it's okay that they don't know. So a simple, how did you do it? It was just like, oh, you don't have to answer that with specificity. You can say, I went through some stuff, and leave it alone. They'll gauge by your face that they don't want to dig any deeper. So, it really is up to you, but you don't owe anybody an explanation for how it happened. And you can tell as much of your story, as little of your story as you want. At the end of the day, you keep doing you. OJ wrote at 7:19 p.m. What are some things I can do today to help deal with ARFID? Dr. Curiel.
I would kind of go back to some of the things that we have talked about. Maybe it is writing down some of your values and starting there. Maybe it's starting from a place of what am I willing to try? Can I break this down to something small? And knowing that, pushing yourself a little bit out of your comfort zone is where you're going to get some growth, and like just kind of keeping that in mind. And, the goal with when you are going to be doing exposure is to try not to engage in compulsions and avoidance at the same time, before, during, or after, like the whole running to compulse after. I would say, just keep those sort of larger things in mind and some specific things, and start where you feel like you can. Like, can you make some concession where something is a little uncomfortable or a little imperfect or doesn't feel right, maybe is a little scary, and kind of once you get some mastery with that, build on from there.
Thank you. Kyle, any thoughts?
I mean, I guess it's what's the smallest amount of anxiety you're willing to tolerate? And then, take the biggest bite you can while being able to tolerate it. The biggest problem that I have when I try to start thinking of little things to do with my OCD is I tend to get a bit overzealous and then do little compensatory behaviors in my own head that I don't expect. So that's the only piece of insight that I have. Just be wary of compensatory behaviors.
Sometimes it sounds like we're just repeating ourselves over and over again. And the reality is it's because we are repeating ourselves over and over again because, the treatment works. And at a certain, and Kyle, we hope we sound like a broken record because although the treatment is nuanced and the behavioral plans are different for everyone, it's still the same treatment. It's still the ability to live with the uncertainty and be okay not being okay, and radical acceptance and dealing with discomfort and embracing the uncertainty and all of those things. And so, to a certain extent, we always like to say content doesn't really matter. We're in no way invalidating the content and validating feelings, emotions, thoughts, or things like that. But, regardless of how can I do this, how can I do that, the answer is kind of always the same, which is, treatment, clinicians, therapy, support groups, and all of those things. And so, and I think that's a good thing. I think there's a lot of optimism and hope in that. And actually, it was a question that Dr. Daigler answered earlier that I found a lot of hope and optimism in. And it was the question about, that ERP didn't work for me. And I like hearing that there might be a million reasons why it didn't, because that means there's a million reasons why it can. And so, I like to reframe that and be like, oh, there is a chance, there is hope for me. And maybe it's just I need to change my thinking or explore more, or maybe it was the therapists or something like that. So I would derive a lot of hope from that. And I know a lot of people that feel like ERP doesn't work or it's too hard or any of those things, but the reality is it does work. And it's okay that you went through that. And that's completely valid. And you're totally not alone. But then what can we do moving forward? Anna Caroline wrote, 7:21 p.m. is OCD related to neophobia, which I think is a fear of unfamiliar or new things. Is that right?
So neophobia is often associated with trying new foods and new things. So yes, it certainly can be. I mean, in the end, all of these anxiety-related disorders are related, right? We have our nervous systems are a little bit overreactive in some ways, right? We're confronted with this thing, our brain tells us that this is dangerous or it's threatening to us in some way, and we have a response, and that response is intended to protect us, but in the end, it overprotects us, and it winds up limiting our ability to function because of the compensatory behaviors that we develop or the compensatory behaviors that we ask from others in order to try to keep us safe, or in ways that we believe will try to keep us safe, right? So, no matter what the anxiety disorder, really, the goal really is to help kind of retrain your nervous system to not respond with and to confront those things so that you are able to master that feeling and ride out the wave more easily so that you don't have to limit your life and you can live the kind of life that you want to live.
Thank you, Dr. Daigler. Erica at 7:25 p.m. asked, I have contamination OCD. Since the pandemic started, my concern with contaminated food has skyrocketed. How have you dealt with clients who have been struggling with similar issues? Dr. Curiel.
The way that I handled, this extraordinary situation, really, that really I had to pivot the way that I normally work with my patients, because in this situation there was high risk of being contaminated or the COVID spreading. So depending upon how much you had to kind of be out in the public and what kind of behaviors you could do to protect yourself. So the way that I handled that was during the pandemic, we tried to identify like where's the line that they feel comfortable in. I wasn't necessarily asking people to get out and go do all the things that normally we might have on the hierarchy, but we definitely wanted to make sure that within wherever their line was, if they still had to go to work or they still wanted to go to the grocery store or something like that, I would kind of work within that realm. But I just tried to keep my patients functioning as smoothly as possible in their home. So when that came to food, I wouldn't want anything sort of excessive beyond the CDC. This is the way that I approached it. And which was tough because we were hearing all kinds of different things like wash down your food and leave your food in your bags by the door for 4 days and, things like that. So it was a little tough. But I just tried to keep people functioning as smoothly as possible, and definitely wouldn't want to cut out any foods, since we're talking about food specifically, because of the pandemic. So.
And Dr. Curiel, I'm going to stick with you for one more second. Erica also asked at 7:26 p.m., even though orthorexia is typically talked about when eating disorders, do you notice it often occurs with OCD patients as well?
Absolutely. Whether, it has to do with certain ingredients or chemicals, certain diets, the way that food is sourced, animal products, there's all kinds of different things that people can suddenly have rules around their eating, and then they begin restricting and wanting to be sort of pure and perfect with it, to where it is making them overthink and gets mechanical, and they really are kind of struggling to function and maybe avoiding too much, restricting too much, and it becomes an issue. So long story long, yes, very big part of OCD when food is involved.
Yeah, because this isn't really a question, but Kristen at 7:26 p.m. wrote, viewpoints on farm animal treatment is all over. People inject emotion to evoke guilt bias to go with their viewpoint. I don't want to feel guilty for anticipating my decisions. Just worth calling that out, and thank you for that. Second verse, same as the first. Good YouTube name. 7:25 p.m. Could it also be considered ARFID to have the fear of swallowing something not digestible, like a piece of bone or plastic? Go ahead, Dr. Daigler.
It potentially, it depends on how impairing it is, whether that's limiting your ability to consume food to the extent that you're not able to maintain nutrition. Perhaps it depends on how much it's limiting you. People will sometimes, fear choking, fear vomiting, fear ingesting something that will make them sick, and so they start to restrict to the point where it negatively impacts their health. And that certainly could qualify for an ARFID diagnosis. Absolutely. It really depends. I mean, we see that too with, other kinds of OCD, like sensory motor OCD, right? When some people are hypervigilant to the swallowing sensation or hypervigilant to the chewing sensation, to the extent that it causes anxiety, and they start to restrict their eating or restrict their consumption because of it. So we see that, I think, in ARFID as well as in OCD that doesn't quite meet criteria for ARFID, but is certainly food-related OCD. I
relate to that. Fish bones, chicken bones, anything sharp, because I would have intrusive thoughts about it ripping my stomach or and killing me. I always go straight to death. I skip all the middle stuff. And actually, Kyle, Erica asked Kyle where you went for treatment, and what we'll do is, Erica, if you would email, we'll give an email address at the end. If you just shoot us an email with that question, we'll have Kyle respond to you. But I didn't want you to think I missed that question. Gretchen at 7:29 p.m. asked, my adult son with OCD has gained a lot of weight these last 2 years. I attribute this to a very poor diet. He is now obese, and I worry about his physical health, not just mental health. He refuses to go to a general practitioner. He went through a PHP virtual program for ERP, but now is stuck. Any suggestions? Go ahead, Dr. Daigler.
So if he's seeing an outpatient therapist, that is certainly something that could be addressed. There could be a lot of different things that contribute to weight gain. It could be mood. Depression secondary to OCD could potentially contribute. It could be the side effect of medication. It could be other kinds of metabolic problems that contribute to weight gain. So there are a lot of other kinds of problems that could potentially explain or contribute to gaining weight. But even a therapist could potentially assess for some of that and perhaps even help him to evaluate whether or not it's worth it to explore and rule out any kind of medical, underlying reason for weight gain, and also work on some behavioral activation, in small steps, getting him a little bit more active, perhaps changing his diet in ways that would be more helpful for him. So I think that even working with a therapist, if that's something that he is doing, as opposed to his unwillingness right now to see a primary care physician, could potentially be a good place to start.
Dr. Curiel, did you have any additional thoughts?
No, the only other thing that I was thinking about is just, maybe allowing the therapist to hold that piece and kind of see where the patient is regarding their weight, and, as far as the timing and how much to emphasize and when to approach. It's a delicate topic. That's all.
And actually, Fran, thank you so much. Put a link at 8:12 p.m. Or the email, I should say, to the IOCDF. So if anybody has any additional questions or wants to follow up with anybody on the panel, I'll say this again at the end, please feel free to email there. Before I get in trouble with Kristen, there was a question. And so at 8:11 p.m., advice when animal food products and your personal convictions of OCD entangle themselves. I get fear, guilt, and shame that I am eating a product that has not been treated well. Go ahead, Dr. Curiel.
Well, I will just say that I can kind of relate to that because I don't eat animal products myself. So I know what that kind of push-pull feels like that you're referencing. And I will tell you this, I think both, from a personal and professional standpoint, that sort of striving for purity is more likely to get you, cause you more distress and more discomfort, and won't get you as far. Just like you have to get more comfortable with OCD, or with uncertainty in general with OCD, that means sometimes letting go of perfectionism or maybe even some acceptance with certain things. I don't know if you're someone who does or doesn't eat, animal products based on your question, but I think that's just like a personal choice, and be careful about self-punishing and excessive guilt with scrupulosity, that can come up as well. So.
Go ahead, Dr. Daigler.
Yeah, I would also add that, whether it's moral scrupulosity or whether it's orthorexia, where you have a concern for, healthful eating habits to the extent that it's causing a great deal of distress and avoidance and anxiety. I think it's important to draw a distinction between having strong moral convictions and feeling, strongly that you want to eat a particular way versus feeling like you need to. And if you don't, it causes a great deal of distress and anxiety and drives you toward compulsive behavior. Those are very different things. So if doing so is causing you a great deal of distress and you're getting wrapped up in reading food labels, asking grocery store employees about where the food was sourced, or, other kinds of ritualistic behaviors, that sounds more like OCD is grabbing on to this thing that's important to you and that it's negatively impacting your functioning. So that's probably something to work on in terms of just being able to be a little bit more flexible, even if you decide that these things are still important to you and you still want to live that kind of lifestyle.
Kyle, I know you have insights. Go ahead and share them.
Okay, the question actually brought up, it reminded me of a story of my mom. My mom was vegan for 5 years, 4 years before I had OCD. And then the year that my OCD kind of blossomed, she was still vegan the whole time. And I used to joke with her about how, why can she be so rigid about her eating habits when I can't be rigid about, how I wash my hands before I go to sleep. And when I kind of was in the latter stages of my treatment, we went to a camp where me and my therapist, and I think Ethan was there, we kind of had a powwow to end out my treatment. And my mom had a Big Mac in front of me to prove that she wasn't rigid and that she could do whatever she wanted. So I think it's to me, it's a question of rigidity. My mom, it was an OCD because she could eat a Big Mac if she wanted to. And, she felt a little guilty, but it wasn't going to stop her from eating it if she craved it. So it wasn't disorderly. But if she had never wanted to go near a Big Mac, and if she even poked it, then all her amygdala would fire up, then that seems more disorderly. So, I guess just being flexible and knowing that you can do that kind of stuff and testing out your boundaries and trying to make sure that you're not a little too rigid.
And I'll say that that's true across the board, right? With all of these food things that we're talking about, rigidity is where we might be running into trouble.
It's true with OCD in general.
Mm-hmm.
OCD loves rigidity, and flexibility is really where it is, really where the key is. And it's also important to remember that, OCD is ego dystonic. It's not trying to move you toward your values, and so it moves you away from your values. And it's the same with religious scrup, right? It's this idea that, I don't want to go against my values or eat something that I'm not supposed to, or do something. The reality is OCD will pull you away from that. So by diving into the discomfort and being flexible and addressing it with treatment and properly teasing it out, I'm not saying throwing away everything, but properly teasing out with the help of an expert, that will help you lean into the things that you care about most. So if you care about, being vegan or making sure you're eating, food where animals are well cared for, whatever that looks like to you, you can best do that with a clear, objective mind and lots of insight, right? Where OCD is not dictating and making decisions for you. So sometimes looking at the bigger picture is really helpful in that regard. Summer at 7:32 p.m. said, I've been turning to eating as I've been recovering from OCD. I've even had other urges normally unusual for me, such as drinking. I imagine this is common as you are learning to resist compulsions. Dr. Daigler?
It can be. People turn to all sorts of different ways of coping with their uncomfortable internal experiences in order to get through. And sometimes those are helpful, healthy, adaptive ways of coping, and sometimes not so much. So yeah, I mean, sometimes people do turn to different kinds of coping mechanisms that are not in their best interests and are not helpful to them. That's definitely something that's important to work with your therapist on, because you can talk to them about developing other ways to work through that discomfort instead of turning to ways to try to further avoid or push away that discomfort.
Thank you. This is a great question. 7:33 p.m. Taryn asked, do you have any tips for parents to be proactive with their kids with OCD around this topic? We get, obviously, parent-kid questions so much. So I'll let Kyle weigh in a second. Dr. Daigler is feverishly nodding her head, so she gets to go first.
Oh, yeah, parents. We've gotten through nearly an hour and a half and didn't talk at all about family accommodation. Wow, that's amazing. So perfect time to bring it up, I suppose. It's really important to balance being empathic and supportive of your child, while at the same time encouraging them to push through their anxiety and being confident in their ability to cope and in their ability to deal with the discomfort, rather than providing them with reassurance or engaging in different kinds of rituals for them because they're uncomfortable. It's so natural for us as parents to want to comfort our kids and to want to help them and bring down their distress. But, you know, the short-term comfort, long-term problem. So we have to keep our eyes on the long-term solution here. And the way to do that really is to be able to say to our kids, I know this is uncomfortable, but I also am really confident that you can get through this and that you can handle this, and let them get through it, and try not to accommodate the anxiety by doing things that would artificially bring it down.
Go ahead, Dr. Curiel.
Just to add to that, you know, at least with smaller kids, the therapist is likely to have you in session and very involved in the treatment and implementing things at home, and you know, reinforcing the healthy healing type behaviors. So you can approach it, if you know kind of what, you know, the kiddo is working on, you can approach it gradually with them. You'll know where they are and kind of where they're headed. And it is a little bit of a dance, and to me it depends on the type of communication that happens in the household, if there needs to be shifts, or if the style works but maybe what we're saying we want to you know, get away from reassurance, those kinds of things. Make challenges you know, a part of the household, and maybe the parent doesn't have the same reaction to that food as their child, but they're going to model like, hey, I think this is kind of weird over here, and we're going to do something together, you know, tonight. We're going to both challenge, and so that they can see that, you know, you can tolerate discomfort, and the takeaway being that we all can tolerate more than we think we can. And sometimes the anticipation is the worst.
Kyle, what was beneficial for you in terms of your relationship with your parents during this time?
Well, I mean, with food specifically, I would say my parents, they knew about OCD, they knew about accommodation when my eating disorder started developing. So they recognized that I was being rigid, and more rigid than I'd ever been in my entire life. And they tried to shake me up a little bit, but I wasn't having that. And then that ended up leading me down a path that I wish I hadn't gone down. So to Dr. Daigler's point, don't accommodate. But I would say the most important thing is just be aware of rigidity. Know that, you know, it's good to be flexible, that OCD likes when you get stuck in a rut. And if your kid looks like he's getting stuck in a rut about food, well, then that might be a place to have a conversation, a time to talk about that. Maybe try to introduce some flexibility. And if they respond with like a huge anxiety flare up, well, then, you know, that could be a signal that there might be something there to address with a therapist. What worked well with me and my parents was, and this is difficult to do with a teenager, and I wasn't the best at it. Me and my parents, you got to talk to your parents. And I didn't like talking to them about my OCD. So what we did was we had 15 minutes every Monday where they could ask questions and I couldn't get mad if they asked those questions. And after those 15 minutes, I could get upset if they asked me about it. But during those 15 minutes, we had our exchange about like, okay, this is what I need help on. This is what me and my therapist are working on. If you notice me gravitating towards grilled carrots, well, then tell me like, hey, Kyle, don't do that. Maybe have this Pop-Tart instead. So I think having that structure was really helpful.
How involved were your parents in treatment?
With OCD, they were not very involved, and then they became involved, and then I got better. So they were very involved towards the end, and that meant a lot. And in terms of eating, my dad was just incredible with my eating disorder. I was on a 4,000 calorie a day plan to get me weight restored, and he would eat my exact diet with me. So he ate my breakfast with me, and then we had a morning snack, and he would have an Ensure with me and 2 cookies. And then we had the same lunch. We had an afternoon snack together, another an Ensure and 2 cookies, and then dinner together. And him being there with me every step of the way made all the difference. And like, it meant so much to me having a parent walk me through the process. So if you're able to be involved with your child as they go through something like this, coming from the bottom of my heart, it's one of the reasons that I was able to make it out.
I love that, Kyle. And I have the same story, right? If it weren't for my parents engaging in tough love and everything they had to do for me, I definitely wouldn't have made it out either. So that's why it was important to bring up. We have 3 minutes left and actually 1 question left, which is super rare. We usually don't get through to all of them. So I'm going to quickly ask it if we don't mind going just a couple minutes over. Everyone okay with that? Okay, perfect. At 8:06 p.m., this is a big question. Pilar asks, eating every day is a battle due to contamination OCD, among other million everyday little things to do. It's just so time, energy consuming to just do regular stuff that I'm not able to move on. How can one make time to continue the battle? I think we've touched on this in various ways throughout the evening, but maybe if we can go around and each give a piece of advice regarding, that's a good way to end this. Go ahead, Dr. Curiel.
Well, you bring up a good point about, OCD consuming time and energy. And it's interesting you say that, because I'm always telling my patients we want to get to a place where we're not giving OCD the time of day. And I don't mean that in a purist black and white sense, because that's usually not helpful either. But I think trying to make decisions and choices where you can, in line with your values, like we mentioned, and making time for your values and less time for OCD, and just keep trying to go, in that direction. And you can take 1 step at a time. And sometimes I think here's where willingness can really come in, is sometimes we have to make choices not based on how we're feeling, but based on our commitment to ourselves, our commitment to getting better, our willingness to do the hard thing, so that we can have the life that we want.
Thank you, Dr. Curiel. Go ahead, Dr. Daigler.
So another thing that you can do is to really just start to peel back the time involved in all the different rituals that you have in related to food and contamination. So, if you're spending 5 minutes at a time washing, for example, and you're using 5 pumps of soap, start to scale that back to 4 minutes and 30 seconds and 4 pumps of soap, and then slowly scale back from there. So, you're not likely to be able to eliminate everything all at once, and you're not even necessarily likely to totally eliminate a ritual when it becomes so time consuming, but think about trying to scale it back, or trying to change the ritual in some way, try to change the compulsion so that you're still leaving there feeling a little bit uncomfortable, just to try to make a little bit of headway, aside from doing, organized exposure and response prevention. Just try to change it in some way and try to scale back the time involved little by little.
Well said. Kyle, what are your thoughts?
In reference to being able to just balance kind of contamination OCD around food and just doing normal things, I would say that mental health is, and I found it incredibly important to make it very obvious that it's a priority. When I had anorexia, I've always prioritized my education, and I had to drop out of high school or take a leave of absence for a little while to go into residential treatment for anorexia. And I was kicking and screaming when my parents dragged me out of my high school because I wanted to go to college. I wanted to like keep learning. That's what I'd always wanted to do. And I didn't like their decision. They forced me to do it. And I've never been more grateful for a decision that my parents have made for me, because prioritizing my mental health allowed me to go on with the rest of my life. So it's a bother that it sucks up all your energy, contamination, OCD, but you got to make it a priority in your daily life to beat back your OCD, because that's the only way that you can move forward with your life.
Thank you, Kyle. And the last thing I'll say, Pilar, is, Dr. Curiel touched on it definitely, which is about willingness, right? And obviously you need the education. We can't be faulted for not knowing things before we learn them. So you need the education to realize this. But one of the things that you wrote in your question is you wrote consuming to just do regular stuff that I'm not able to move on. And that not able is what I want to focus on, because I know, and Kyle can speak to this too, that OCD and compulsing very much feels like you don't have a choice. It feels like you just have to do it, but really it is a choice. Not moving on, compulsing, that is a choice. So we'd want to take that and say, I'm not willing to move on. And I know that says harsh. It seems really harsh, and I'm in no way attacking you whatsoever, but it's important to note that it's recognizing that I am choosing this behavior because it is a choice. And granted, you need guidance and therapy and in order to get that insight and objectivity to be able to make that choice, because at the beginning, those thoughts are right here. You can't see anything else. And so it feels so automatic. But I want to recognize that at the very beginning, just recognizing that you have a choice, and can you get a little separation between you and your thought? Dr. Daigler probably recognizes I'm doing some act things right now, moving the thoughts to and from my face, and she's getting really excited, and we'll talk about it later. But hopefully everyone got some great insight from this. So thank you, Pilar. Thank you so much for that question. And with that, we are out of time. So first of all, I want to thank our guests, Dr. Daigler, Dr. Curiel, and Dr. King, or upcoming Dr. King. Well, I'm giving you credit for later on. Kyle, for joining us tonight. Thank you so much. It's been a great conversation. Real quick, some housekeeping, so don't leave quite yet. So first of all, we had lots of kid and family questions. July 10th and 11th is online OCD camp. It's for kids and teens age 4 to 17 and their families. It's going to be great. You can go to iocdf.com/conferences. Is that the right link, Fran? If you want to check out or sign up for the OCD online camp, as well as view all of the conferences that the IOCDF is having over the summer, which is a ton. I think we're doing 6 conferences in total from May to October. Also, you can check out all of the programming the IOCDF is having over the next year at iocdf.com/peace of mind. So it's that website right now. And if you haven't already and want to be notified about all the programming the IOCDF is having over the next month, please be sure to follow and subscribe and follow on Facebook and Instagram. You can also follow us along on Twitch. There we are. Kyle, keep the graphic up. Kyle, keep the graphic up, Fran. Kyle, can you stand up just a little bit? Perfect. Yep. That's thank you. Appreciate it. So, with all of that being said, I wrapped up very quickly because I know we're a little bit late. Again, I want to thank Dr. Daigler, Dr. Curiel, and Kyle for joining us. We have tons of programming next week, so check out that link, see what we have going on. So, thank you so much for spending your Thursday evening with us. Finally, and the link was in the thread. If you have any additional comments, questions, if you have comments or questions for our guests, please feel free to email the IOCDF at info@iocdf.org, and we'll be sure to answer your questions or get the questions to these people so we can answer your questions and get it back to you. So with that, as I always like to say, have a wonderful evening. Stay safe, stay vigilant, feel all the feels. Don't let OCD off the hook, and we'll see you next time. Good night.